Thank you very much. Good morning, good afternoon, good evening to everyone who have joined us. Welcome you to the seminar sponsored by the International Society for Biopharmaceutical Statistics. Today, it is our pleasure to have Dr. Naitee Ting to give us a seminar on what you may not know about ITT. So please allow me to introduce to you Dr. Ting, who is a fellow of American Statistical Association, is currently Vice President of StatsVita. Naitee is also Adjunct Professor of Department of Statistics at University of Connecticut, Adjunct Professor of Department of Biostatistics at Columbia University. Before joining StatsVita, Naitee served at Boehringer Ingelheim and Pfizer. So without further ado, I'll hand over to Naitee. Thank you very much for joining us.
Thank you, Don, for the introduction. Appreciate it. There's something new just happened to me, so I wasn't able to update my material for Don to give you the current situation. I just joined a new company called Verimed, so that'll be my new affiliation. Let me share my slide. Okay. So Don, you can see my slide, right?
Yes, in the presentation mode. Thank you very much.
Okay, that's great. So as you see, I sort of made this change on my screen. The the point I want to make today is about intention to treat. I think everybody heard about intention to treat, and I try to get some more clarification. And I want to have this discussion being interactive. So I welcome comments, questions, or anything during my talk. If you have any thoughts, feel free to unmute yourself and we can discuss. And I welcome debate also. So I start with a very simple question about drug approval. I say if a company developed a painkiller and the first patient took it and the pain relieved, the second patient did the same, and after many patients experienced pain relief, and now this company documents all these cases, and they call it a series of case reports, and submit to the FDA. So if you're the FDA reviewer, can you approve this drug? So we know that before 1962, there was no clinical trial supported drug approval. But after 1962, the Congress request FDA to approve drug based on clinical data. And so from FDA's point of view, after they're experiencing with the clinical trial data, of course, they know we cannot approve this drug just on a series of case reports for two major reasons. One reason being the natural progression of the condition. For example, we all have this experience. We experienced some very severe pain, but we did nothing, and then the pain relieved. So it's just a natural progress for this case. And the other thing is placebo effect. I think many of you are in the pharmaceutical industry, so you're aware of the how strong placebo effect could be. So it's either the natural progression or placebo effect, and the fact that feeding is subjective. So we cannot approve a drug simply based on each patient's own experience. So we need to sort of come up with some way to overcome this subjectivity from a drug efficacy point of view. I think everyone here is aware of that. We're approving drugs based on the hypothesis testing setup. So the hypothesis testing says the following. Let's see what's going on. Oops. All right, the hypothesis testing says the following. If we have two distributions, so the null hypothesis says the test drug and placebo are no difference. But the null hypothesis says we cannot separate these two distributions. If we can somehow separate these two distributions, we can reject the null. And so we're not trying to prove the drug works, but we're trying to prove that the probability the drug does not work has a low probability. So let's go back to the statistical hypothesis testing framework. We randomize patients into two groups, test drug and placebo. And null hypothesis says the test drug is no different from placebo. Only when there's sufficient evidence to show the two treatments are different, then we reject the null. So what this says is that now if I can measure the pain reduction of each patient, I have two groups of patients, we randomize them into test drug versus placebo, but every patient experienced pain relief, and we look at the pain at the baseline and the pain at endpoint. We subtract the baseline from the endpoint, we got a number. And so we have the placebo-treated patients, we have all these pain reduction number, and we organize it as a histogram. So a histogram looks like a normal distribution. And then we do the same for the patients who took who were randomized to the test treatment, and they have another histogram. And then we look at these two normal distributions and see if we can separate them. So if we can separate these two distributions, we reject the null. If we can't, we say your test drug is no different from placebo. So when we say the null hypothesis being mu t equal to mu p, that does not mean that the average of the pain reduction of test drug and placebo are exactly the same. That's not what it says. The null hypothesis says these two distributions are not separable. Only when you separate these two distributions, the two means are far apart, and then you reject null. So the question is how far apart they should be if the p-value is less than alpha. Then what you say the test drug could still be a placebo, but that probability is controlled under alpha. So that's what I was just trying to say. I'll say this is a placebo distribution, and this is the test drug distribution. If these two distributions are far apart, then you reject the null. So what you do is based on your data, if you found your observed z value, for example, or t value, or whatever, is to the right of this critical point, and we say under null placebo distribution, there's a low probability that the drug does not work. Okay, let me try this again. Under null, this is a placebo distribution. Under null, if you observe something sort of to the right of this critical point, under null means the drug doesn't work. But it looks like it may work, right? So under null, then you observe something to the right of the bar, you reject the null. So FDA does not say we approve the drug because it works, but says because the probability the drug does not work is controlled under alpha. So this part of the probability is alpha. And the other alternative if you just extend this line to the left of this line, this part is beta. And to the right of that line, this part is power. So that's what I try to say. You try to separate these two distributions. If you cannot separate it, you accept the null. But you accept the null, you didn't say the drug is exactly like placebo. You just say there's no significant difference between your test drug and placebo. So there's only one truth. The truth is the drug doesn't work. Or the truth is the drug works. There's only one truth. We never know whether the drug works or the drug doesn't work. We don't. But based on the data, we have to make a decision. We have to decide whether to accept the null or to reject the null. So if the truth is the drug doesn't work and you accept the null, you're doing okay. If the truth is the drug works and you reject the null, you're doing okay. But if the truth is the drug doesn't work and you reject the null, and that's type 1 error, that's alpha. If the truth is the drug works and you accept the null, then you're making a type 2 error, and that's beta. Okay. The whole thing about sort of randomization, modern clinical trials, and everything, it originated from about a century ago, this lady tasting tea example. So about 100 years ago, there was at Cambridge, UK, they have a afternoon tea break. So in this tea break, the faculty members are there, and the waiter comes in with a tray. On top of the tray, there's cups, and there's a pot of tea. There's a pot of milk. So this professor grabbed the cup and poured the tea into the cup, and then poured the milk into it. And then there's a lady said, if you want the tea to taste better, you should pour the milk in first, and then you pour the tea into it. This is a true story. This lady is Mrs. Bristol, and this faculty member was trying to pour in the tea and pour in the milk, and then she said, if you want it to taste better, you pour the milk in first and tea after that. And then they began to discuss, can the lady tell the difference? For a given cup of tea, whether it's tea first or milk first, can she tell the difference? So another faculty there was Fisher. I would consider the father of modern statistics. So Fisher said, I can set up an experiment and try to see if the lady can tell the difference or not. And here's what you do. You have the waiter prepare 8 cups of tea with 4 cups tea first and 4 cups milk first, and ask the lady to taste. This lady could be purely guessing, but she can guess probably 0 cup correct, a few cups correct, or she can guess all 8 cups correctly. If she can guess all 8 cups correctly, the probability of purely guessing is very low. So we're talking about this 2x2 table where the waiter actually pour 4 cups with milk first, 4 cups with tea first. And the lady could guess 4 cups with milk first, 4 cups with tea first. The probability that she can guess all 8 cups correctly can be calculated. So this is a hypergeometric distribution where the denominators 8 cups choosing 4 cups, which is 70, right? 8 factorial divided by 4 factorial divided by 4 factorial. And the numerator is 4 choosing 4 multiplied by 4 choosing 4, which is 1. So the probability she got all 8 cups correctly is 1 in 70. And we would say she may not be guessing. She may be able to tell the difference. So here, the null hypothesis is the lady is guessing. And the alternative hypothesis says she can't tell the difference. So the result after that experiment, Mrs. Bristol got all 8 cups correctly. So this was about 100 years ago. And then Fisher uh, sort of published this experiment in the 1930s. And then the first clinical trial was 1948. And then 1962, there was this Kefauver Harris FDNC amendment that starts the whole clinical trial. And then FDA would require clinical evidence in order to approve drugs. So the probability of guessing correctly can be quantified. Of course, we can increase the number of cups, or we can randomize 100 patients, 50 to placebo, 50 to test drug, and that became the double-blind randomized controlled clinical trials. So let me give you an example here. Suppose I want to lower blood pressure. Okay. In a clinical trial to study test drug for lowering blood pressure, 2 treatment groups, test drug versus placebo, with balanced allocation 1-to-1 ratio and randomized with block size 2. And we'll want to measure the change in blood pressure from baseline to week 4. So I'm doing the same thing. Again, I'm looking at 100 patients, for example. I randomize them 50 on test drug, 50 on placebo, try to lower their blood pressure and see after 4 weeks, are their blood pressure lowered. So at baseline, you randomize these patients. Before randomization, you have their baseline blood pressure measurement. And then you can have weekly visit. And at week 4, you have another blood pressure measurement. You use the week 4 blood pressure minus the baseline blood pressure. And you got a negative number, and you try to see if there's if the test drug could lead to more blood pressure reduction than the placebo. And again, you're looking at 2 distributions, and you try to separate these 2 distributions. So that's how we designed the clinical trial. So here I'm talking about randomized with block size 2. In other words, from clinical trial setting, we're shipping drugs to the investigator. We're shipping drugs to different centers. So we ship these drugs by block. And a block size 2, that means if the first patient is randomized to A, the second patient is randomized to B. If the first patient is randomized to B, the second patient is randomized to A. So it's A, B, or BA. And if I have 100 patients, I have 50 blocks. And each block has 2 sort of drug supply for 2 patients. So let's look at this normal distribution. I think most of us are very familiar with this normal distribution. The question is how did we put this normal distribution together? So if you recall, when you went to school, the first statistical course, the professor says, if I have a normal distribution, I have a random variable x, and x has a normal distribution with a mean mu and variance sigma squared. So this is my normal distribution, and this is my population. Okay, so I have all the patient population with high blood pressure. All right, we have the whole population. And suppose there's a mean mu and variance sigma squared. Now, if I take a sample size n, I got an x bar, which is the mean of these n subjects. And I take another sample, I have another sample mean x bar. So we can keep sampling, and we can look at all the sample means. And these sample mean, we put them together as a population. this X bar has a distribution of mean, mu, and variance sigma square over n. So that's how we learned about how to construct this normal distribution. Okay, so that's what we call asymptotic theory. But when Fisher goes through this lady testing T, it's actually based on permutation because there are 8 couples of T, and there are 8 choosing 4 ways of combination or permutation to arrange these 8 couples of T, and then the lady will have to guess it, right? So we can, based on asymptotic theory, we can do a sample from the placebo distribution. We can do a sample from the test drug distribution. We try to see if we can separate them. So that's asymptotic theory. But permutation theory looks different. Remember, I have 100 patients, okay? And I'm looking at only the first 8 of them. And patient number 1 was randomized to A, and after 4 weeks, this patient reduced 8 millimeter mercury of blood pressure. Patient number 2 was randomized to treatment B, and after 4 weeks, reduced by 2. Patient number 3, randomized to B, reduced 4, and so on and so forth. So you look at the A bar minus B bar, okay? So A bar being minus 8, minus 7, which is minus 15, and minus 9, that's minus 24, and minus 4, that's minus 28. So A bar is minus 28. And B bar is minus 2, minus 4, which is minus 6, minus 3, minus 3, so minus 12. So A bar minus B bar being minus 28, subtract minus 12, you got minus 16/4. Of course, I have 100 patients. These are just the first 8 patients, okay? And there's a mean difference of minus 16/4. Under null, the number 1 patient, the first patient, whether this patient was treated by A or treated by B, is no difference. Under null, mu T equal to mu P. Test drug mean and placebo mean is the same. Okay, under null, it doesn't matter that patient A received A or B under null. Okay, same to every patient. So from Fisher's derivation, then if under null, whether the patient actually received A or B does not matter, then we can permute these labels. Remember, I randomized these patients with block of size 2, right? So I can re-randomize this block as AB, this block as AB, this block as BA, or so on and so forth. So I can permute these labels. Now, if I permute all my blocks, which is 2 to the 50th power, okay? So the next permutation, I got BA, AB, AB, BA, okay? So based on this permutation, the A bar minus B bar would be, all right, minus 2, minus 4, that's minus 6, minus 9, that's minus 15, and minus 3, that's minus 18. A bar being minus 18 over 4. And B bar being minus 8, minus 7, that's minus 15, minus 3, minus 4, that's minus 22. So B bar is minus 22, A bar is minus 18, then you got a positive 4 over 4. A bar minus B bar becomes a positive number, right? And I can keep permuting all my 50 blocks, right? I can just permute. And then if I look at the A bar minus B bar out of 100 patients, A bar minus B bar out of 100 patients, I got all these numbers from permutation. And then these permutation will give me a normal distribution. Okay. So this is a very important concept. This is very different from the asymptotic theory. Asymptotic theory says the treatment difference came from I take a sample of patients treated by test drug. I take a sample of them, and then take another sample treated by placebo, and I look at their mean difference, and I can perform the traditional t-test or z-test, whatever, to see if there's significance or not. That's the asymptotic test. Permutation test is different. Permutation test is all I have is these 100 patients. And I can simply permute the labels and formulate a normal distribution like this. And as you know, this distribution has a mean 0, right? And then we'll look at this one. We'll look at this true realization. We'll look at this one to see if it's to the left of this red bar or not. If it is to the left, we say it's statistically significant. All right, so this gives us the alpha. From here to the left is alpha. So if the treatment difference of these 100 numbers, we calculate the mean compared to this permuted normal distribution, and if it's to the left of the red bar, we say we reject the null. All right, so remember, we don't say the drug works, but we say the probability the drug does not work is controlled under alpha. And of course, if you look at these numbers, and if it falls to the right of the red bar, you say it's not significant. We say we cannot differentiate these two distributions. The test drug and placebo look alike. Okay, you fail to reject the null. So this permutation theory is different from the asymptotic theory, even though both theory establish the modern statistics. But the Fisher approach is very different from the Neiman-Pearson approach. Okay? So that's a permutation setting. Any questions so far? Any comments? If not, I'm going to move on to the next slide. Okay. Here, the question is about if a patient is randomized to A, but the patient actually took B, how should we analyze the data? Well, keep in mind that we won't find out what the patient is taking until the blind is broken. So after the study completes, and you found, whoops, this patient was randomized to A, but actually took B. Remember, today we're talking about intention to treat, ITT. Remember, the intention to treat has two principles. The first principle is report all data. The second principle is analyze as randomized. So if the patient was randomized to A, but actually took B, why intention to treat says you have to analyze the patient as if the patient received A, but not B, even though the patient actually received B. And that's a key point I want to discuss today. Okay, this is not an easy concept. Intention to treat, analyze as randomized. Why? Okay, now remember, across all the permutation, there's only one true realization, which is based on this randomization, ABBA, AB, AB, and we got this mean. That's the only one we have. okay? And anything else is a permutation. So the fact is that if the patient is randomized to A, but actually took B, you analyze the randomized, you got here. But if you analyze if the patient took B, you got here. So this analyze as randomized is not significant, but analyze as treated is significant. Then why do I say I have to analyze as randomized? It is because whatever happened here is one of the permutations. It's not the randomization. We randomize the patient based on this randomization, and that's what the patient is supposed to take, and that's what the patient is supposed to respond. Any other permutation is only used to construct this normal distribution. So there's only one truth from these permutations, which is the randomized sequence. Okay? So if you analyze as treated, in this case, it's one of the permutations. The permutation looks significant. That's not right. It's one of the permutations. All right. The whole key about drug approval is about alpha protection. If your procedure violates alpha, you cannot use that to approve a drug, because the drug is approved because the probability the drug does not work is controlled under alpha. Now, if you analyze as treated, alpha is inflated. Okay, so that's the guts of intention to treat, analyze randomized. But the first principle of reporting all data, we know that. I mean, we know after performing clinical trials, we cannot exclude any patient. We have to report everything that we observed, right? But when you analyze, you have to analyze as randomized. And that is because if you do not analyze as randomized, it's one of the background permutation, and the background permutation is not the true randomization. And the foundation of modern drug development, drug approval are all based on randomization. So whatever we do, we have to respect randomization. Again, this is not a very easy concept, but it's very important, very critical. That's a foundation of modern drug development. Any questions or any comments? If not, I will move on. We know in public health, we study epidemiology. Okay, epidemiology, we simply follow patients, we follow the disease, you follow the condition. And from epidemiology, we look at diseases, we look at exposure, we try to establish some kind of association between disease and exposure. All right, so epidemiology is observational in nature. All you can do is observe what happened. There's no randomization, okay? So in epidemiology, there are cohort studies, there are case control studies, and there are cross-sectional studies, longitudinal studies, there are all other studies. But cohort studies, there are two types. There's prospective cohort studies, and there's retrospective cohort studies. So prospective cohort studies is that you recruit a number of participants and you just follow them over time. That's prospective. And of course, we know one of the most famous cohort study is Framingham study. In Framingham, Massachusetts, I think back in the mid to late 1940s, we recruited over 5,000 Framingham residents. And I think for every year or every half a year, they come in, they fill out the case reports about their lifestyle and their health condition kind of stuff. And Framingham study is still ongoing now. Many of the original participants already passed away. We're following their offsprings. So there's still over 4,000 participants in Framingham study. It's a prospective cohort study. Now, retrospective cohort study is you go to the hospital, you review the patient's charts and try to look at the patient's history. So it's retrospective cohort study. And case control study is, well, if you want to study the relationship between smoking and lung cancer, and we know it's not feasible to randomize people into smoker or non-smoker and then follow them to see if they develop lung cancer or not, right? It's not feasible to do that. It's not ethical. But how do we establish the relationship or the association between smoking and lung cancer is by looking at case control studies. So case control studies is that you recruit a group of lung cancer patients, and these are cases. And for each of the lung cancer patients, you find one or few matching control, which are people without lung cancer, but probably matching this case with maybe age, gender, or something else. So you have a group of cases who are lung cancer patients, and you have a group of controls who are not lung cancer patients. And then you look at the cancer patients, how many of them are smokers, and the non-cancer participants, how many of them are smokers. You try to establish the relationship from that way. So that's case control study. Now, in epidemiology, because they're observational in nature, the fundamental principle is report as observed. So because there's no randomization, so from a epidemiology study, you have to honestly report what you observe. Okay. So let's look at these two circles. One way of understanding these two circles is that across all the prospective studies, once you perform randomization, it's clinical trial. Okay. So among all the prospective studies, most prospective studies are not randomized. So they're just prospective study. But once you randomize, that becomes clinical trial. So you can say that clinical trial is a subset of prospective studies. So that's the first way of looking at these two circles. Another way of looking at these two circles is when you run a clinical trial, in this clinical trial, after completing the study, you have three sets of data, mainly, sometimes there's some other data, but mainly there are baseline demographic data, there's efficacy data, there's safety data. That's three major sets of data. Sometimes you have other data sets also, okay? In these three sets of data, which set we should analyze as randomized? It's only efficacy. Because the randomization is based on the hope to separate these two distributions. So intention to treat has to follow for efficacy data analysis. The baseline demographic data and safety data are observational in nature, even though they are all also from the randomized patients. But when you design the study, your objective was trying to separate the efficacy data between test drug and placebo. So you design the study from an efficacy point of view, you calculate sample size, everything based on the primary objective of separating the two distributions from efficacy point of view. And by the way, when you collect efficacy data, you also collect baseline demographic data and safety data, but you would never hope the demographic data are separated or safety data are separated. All right, let me give you an example. If the two groups, there's a gender difference, say test drug has 40% male, and placebo group have 60% male. You got a gender imbalance, and you submit this study to FDA. FDA will say, well, it's not a treatment difference, it's gender difference. It's confounding. So you don't want your baseline demographic to be separate. You want your baseline demographic to be as similar as possible. That's why you go through randomization. You want these patients being as similar as possible by nature. And if you can separate by efficacy, then you can prove indirectly that your drug is doing something. Same thing for safety. You don't want your safety data to be separated. Safety data are observed in nature. So that's why in a clinical trial, you collect all kinds of data set. Randomization or intention to treat only applies to efficacy data. Every other data set you should be analyzed as treated because it's observational in nature. You have to follow the principle for epidemiology, report as observed. So if a patient is randomized to A but took B, then for efficacy, you analyze this patient as A. For demographic and safety data, you analyze this patient as B. You report as observed. So in the protocol, we see these kind of analysis sets. So for efficacy, ideally, we want to follow intention to treat. But in practice, there are times we may not be able to implement ITT. Remember, we have to report all data. But if a patient took the study medication but never returned, we have no data. We cannot analyze it. Then what you do, you design full analysis set and try to follow intention to treat principle as closely as possible. Okay, and then for demographic data and safety data, you analyze as treated because these are epidemiology. These are observational data. These are not clinical trial data. All right, clinical trial, the randomization is really designed for efficacy. Everything else is observational in nature. So for demographic data and safety data, you follow treated set, analyze as treated. Per protocol set, PPS is typically a subset of ITT or subset of FAS. And we all know this set is biased, all right, because the per protocol set, you have to exclude protocol violations. But this protocol violation is a subjective choice. So by excluding those patients, that analytical results cannot be reliable, cannot be trusted. The only reliable analysis for efficacy is either ITT or FAS. Okay, so that's a brief description of these kind of analysis set, full analysis set, treated set, PPS. Now let me give you an example why PPS is not reliable. All right, so this drug is rivaroxaban, which is Xarelto, all right, which is a newer generation of anticoagulant. So I think rivaroxaban was approved maybe about 13, 14, 15 years ago sometime. It's a newer generation of anticoagulant. And the standard of care at that time was warfarin, okay? Now, warfarin has been on the market, has been approved for probably 40, 50 years. It's available for a long time. is the first generation of anticoagulant, and rivaroxaban is a newer generation. So when you do rivaroxaban or Xarelto, all right, this is a Johnson & Johnson and Bayer drug. So when they try to do their phase 3 studies, they have to compare to warfarin. Okay, so it has to be a non-inferiority study. Now, this is anticoagulants mainly for the prevention of stroke and non-CNS embolism. Okay, so that's what Xarelto or what rivaroxaban was designed to not to treat but to prevent. Okay, now because warfarin is active control and Xarelto is comparing to warfarin, so this turned out to be a non-inferiority trial. I think the non-inferiority margin was something like 1.3 or something. All right, so this is hazard ratio. So you look at the hazard of patients who develop stroke or non-CNS embolism, and you look at the Xarelto patients hazard over the warfarin patient hazard. All right, so if Xarelto has a higher hazard, you got a value greater than 1. All right, if it has a lower hazard, it's below 1. Okay, the hazard ratio of rivaroxaban over warfarin, that hazard ratio, you hope it to be 1 or less, and then the upper limit of the confidence interval of the hazard ratio has to be less than that margin. That margin is 1.3 or something. I forgot the number. All right. So if you look at the intention to treat and the per protocol, they both have a point estimate less than 1 in favor of Xarelto. But the intention to treat, they make non-inferiority, right? I think the upper limit is less than 1.3. It's less than the margin, so it's non-inferior. But the per protocol set, it makes superiority, okay? And let's look at the sample size. The intention to treat with 14,171, and the per protocol set is 14,143. There's only difference of 28 patients, which is about 0.2% difference. But it makes from non-inferiority to superiority. Okay? And here's the hazard ratio for the intention to treat. The upper limit is 1.03, but for the per protocol is 0.95. All right. So if you're at FDA, what would you do? Of course, the drug can be approved for non-inferiority. You cannot approve for superiority. Okay, so personally, I just don't believe in per protocol set. Whatever they define it, it's just 28 patients. The conclusion is changed. Okay, I told you about block randomization, but there's practical issues in block randomization. So suppose I want to do a stratified randomization. I want to stratify by gender. Then I have to have male patients randomized in the block, female patients randomized in another block. All right. Remember, I'm taking a 4-week trial for lowering blood pressure. It's weekly visit. So when I ship the drugs to the center, to the investigator, if I have a block size 2, every time I have to ship 8 bottles. Patient number 1, bottle number 1. Patient number 1, bottle number 2, number 3, number 4. Patient number 2, bottle 1, 2, 3, 4. I have to ship 8 bottles to them. If I choose a block of size 4, it could be AABB, ABBA kind of stuff, right? I can do that. Then every time I have to ship 16 bottles to the site. Now, if I have two stratifying factors, I have gender and age. All right, age being 65 and above or below 65. So I have four strata, and each strata I have to ship 16 bottles to the investigator. So at the beginning, I have to ship 64 bottles to the investigator. But then, if this investigator is a slow recruiter, by the end of the study, this investigator gave me only 3 patients. 2 of them complete the study, and 1 of them dropped out after 2 weeks. So out of the 64 bottles that shipped to this site, they used only 10 bottles. The other 54 bottles are completely wasted. You cannot use it. First, because they're blinded. Even though you can unblind them, by the time you retrieve these bottles, they're they're already expired. Okay. So it's a huge amount of waste. I mentioned 1962, Kefauver Harris. That's the beginning of modern clinical trials. But then in the 60s, in the 70s, we're just running clinical trials, and this kind of waste of study drug was not the main concern. We just try to get the drug efficacy and safety so that we can get approved. But by the 80s, people realize this amount of waste. So there's a new way of randomization. All right, there are actually many new ways. There are a lot of publications in the late 80s. They're talking about minimization. Okay. So for block randomization, only a few stratification factors are practical, and for each factor, there are not too many levels within each factor. And minimization allows for balance in case of more stratification factors or more levels. So what is minimization? Let me give you an example here. All right, suppose I have 4 treatment groups, group A, B, C, and D. And now I have a patient coming in from center 11. All right, if I have 2 stratification factors, factor 1 is gender, 1 is male, 2 is female. Factor 2 is age, 1 is young, 2 is old. If I have a young male patient come from center 11, how does minimization do? So we have to randomize this patient, this new patient from center 11 as a young male patient. So the computer will calculate how many patients randomized to group A. We'll look at center 11 patients. Among all the center 11 patients, how many are A, how many are B, how many are C, how many are D? And then we'll look at all the male patients, how many are A, how many B, how many C, how many D, and all the young patients, and then you sum them up. You got X1, X2, X3, X4. Now the randomization is done in this way. All right, we first define a set of treatment groups M. M is a set of treatment groups such that the Xi's are minimum. Okay, and then the rest of the treatment group being in set M. So example here, suppose in this example, we have x1 equal to 12, x2 equal to 11, x3 11, x4 equal to 13. Then M contains treatment group B and C, and N contains treatment group A and D. So this is a minimization scheme. And then randomness will introduce in 2 different levels. A first random variable dictates the choice between M and N, and the second random number to select the treatment group. So this is just a brief overview of minimization. I think we have just a few more minutes left. Before I move to the next slide, I want to see if there's any comments or any questions.
So yeah, thank you very much, Naitee. Yeah, we only have about 3-4 minutes left. I don't know how many more slides do you have? Whether you want to finish all the slides, or I think there is kind of one comment from the chat. I don't know which one. Do you want to discuss the comment or you want to finish all the
I
slides?
want to discuss a comment.
All right. Yeah, so I don't know. This comment is from Paul Terrio. I don't know, Paul, if you're still with us, please feel
Yeah, can
free.
you unmute yourself?
Yeah. Okay. Okay. So, oh, Paul's mic is not working. I think, yeah, if I could summarize his comment, I think this is more to focus on the discussion around the ITT principle for efficacy, um, and a different approach like per protocol for safety.
Yeah.
Comment is about why can't we use also the ITT for safety as well?
Well, because for safety analysis, very good question. For safety analysis, remember, you're not trying to separate these two distributions. So the safety data are observed in nature. They're not for hypothesis testing. You're trying to learn about the safety of your drug. You're not trying to separate your test drug safety from placebo safety. If you want to, once you separate, that means your drug is too toxic. So the purpose of safety is to observe, to learn, to explore. It's not to use the safety to make treatment comparisons. When people use treatment comparison on safety, it's only after you establish the efficacy and then you say, is the drug too toxic? And that whether the drug is too toxic or not, it can be based on just one safety event or just a few safety events. It's not based on p-value. So there's no alpha problem in safety or in demographic data. Alpha only applies to efficacy.
Yeah, thank you. Okay, yeah. So I think we're close to 11. So and Paul has to leave the session. But thank you very much. Yeah, for the very last minute, any other comment or question to Naidee before we close?
Yeah, I have a question. This is Jay Herson, Johns Hopkins. I think
Hi,
a very,
Jay.
hi. I think a very good way of remembering ITT is the way Peto first defined it, and that is we're randomizing the patients to a policy of being treated with treatment A versus being treated with treatment B. And whatever happens after that, it doesn't matter that much for efficacy because it was the policy. And what the policy is what happens in the real world. Patients stop taking the drug, they've got adverse events and stuff like that. The other thing, in your example with a non-inferiority trial, the PPS has a role there because what Bob Temple said more than 40 years ago, this ITT, these sponsors are using ITT in non-inferiority trials, and they can do a sloppy trial, not follow up and not care about this or that, and that will make it more likely that the treatments will be the same, equal. So we will use PPS. We want the sponsors to compute PPS. However, I don't know of any, when they disagree, as in your case, I don't know of any consistent way that FDA knows what to do.
Uh, Excellent point. Yes, this ITT principle does not apply to non-inferiority. You're correct. But remember, ITT has two principles, one being analyzed as randomized, the other being report all data. So in that Zeraldo case, it violates report all data principle. So if I'm going to analyze non-inferiority trial, I may not use analyze as randomized, but I still use all data.
Yes, correct. Yeah.
All right. Thank you very much for the discussion, and thank you, Naidee, for the great presentation and the discussion. So I think we need to close the meeting now. Thank you, everyone, for joining today. We will distribute the slides and recording afterwards. Thank you very much for joining today's ISBS seminar. Thank you very much. Bye.
Thanks, everybody.